Good morning, everybody, and welcome to this first convocation of the PENAI, the Pre-Eclampsia Education of Nation India program. You're all the first batch of candidates to have cleared the exam. When we were fixing up the passing percentage at 75%, I was really worried whether how many would 75% is a little more. I was all the time arguing whether we should keep it at 60 or 65 and so on. But I'm very happy to note that almost 98% of the candidates who took up the exam scored 75 and have all qualified. I think that's really great, and I think we should thank all the teachers who have probably given some wonderful talks in this program, and of course our behind the scene coordinators who have helped us in formulating this program, working very hard, meeting almost every week to make this program a reality. And of course both Medinit, Manasa has also worked quite a bit. I'm sure she has been arm twisted hundreds of times to make sure the platform works well, and Rosh for supporting this teaching initiative. With this, I would request Revati to go ahead and start the program.
Thank you so much, sir, for that briefing. And I, on the behalf of the Society for Maternal Fetal Medicine India and the International Society for Study of Hypertension and Pregnancy, welcome you all. And let me tell you, perseverance is not just a single race, it's multiple small races put together so that we get to our target. And we believe that each and every session dedicated to PENAI will get us to our ultimate goal about certifying 40,000 clinicians across the country to make a difference. We want to make a difference to all the pre-eclamptic mothers and their unborn babies. So without wasting much time, I would want to introduce our co-chairs. We have Dr. Sarosh Rana, who has joined us from Chicago Live at 10 p.m. in the night. Thank you so much for that, Dr. Sarosh Rana. And she is the professor of obstetrics and gynecology, section chief maternal fetal medicine at the University of Chicago, USA. She is the co-chair of the Global Health Committee at ISSHP. She is the international advisor for the Society for Maternal Fetal Medicine India, and of course, the co-chair global for the PENAI program.
Yeah, if I may add one sentence, Revati, I think Dr. Sarosh Rana has been there all the time behind us, prodding us, helping us out in making this program a reality. Thank you, Dr. Sarosh. Without you, this program would not have been possible.
Thank you so much, Dr. Sarosh. Then we have our mentor, Dr. Prakash Mehta, sir. He's the Chief Division of Maternal Fetal Medicine and Head of Department of Obstetrics and Gynecology of Bhagwan Mahavir Jain Hospital, Bengaluru. He's been a very prominent and a very sought after postgraduate teacher. He is the president of the Society for Maternal Fetal Medicine India. He's been the president of the Bangalore Society of Obstetrics and Gynecology. He's contributed several chapters, and he's also contributed a lot to several journals, both national and international. He's got the Best Teacher Award from ANBI. There are so many accolades to his credit. And most importantly, he is the Indian co-chair for the pre-eclampsia education of the nation India. Thank you so much, sir, for all the mentoring and support. Then, of course, myself, I'm the Chief Consultant, Maternal Fetal Medicine India from I'm from Mirror Health, Bengaluru. I'm also the Secretary for the Society for Maternal Fetal Medicine India, and also the co-chair from the Indian perspective for PENI. So we welcome you all for this gathering. And let me tell you about how this program is going to take on. First, we are going to have the question and answer session. So we have accumulated the questions which have been sent to us by delegates who have completed the course, and most of them have completed the assessments as well. We have categorized them into categorized them into question series. Each question series contains questions which belong to the same or a similar topic, which will be addressed to specific co-chairs, and the co-chairs will be answering this session, these questions. And subsequent to that, we will also have the open house, if possible, where we're going to put in the questions which have come in late, which can be addressed by any of the co-chairs, following which we are going to have feedback from the delegates, the address by the co-chairs, and then the convocation. So we have the first set of questions. This has been addressed to Dr. Saroj Rana. So the first question is, what is the role of SVIT1-PLGF ratio in the categorization of preeclampsia in terms of segregating the patients as those with severe or non-severe PE, which would help decide admission for further surveillance? Dr. Rana, can you please take this question? This is by Dr. Asha Nervi.
Yeah, so thank you so much, Revati, and thank you, Dr. Mehra. And I see Dr. Gupta there too.
Yeah, Dr. Sanjay Gupta has joined in. For those, I'm sure all of you know him, but for those who do not, he's the past president of POXI, and he's the chairperson of the International Justosis Society. And he has, again, one of those persons who have always encouraged us to go further in this field. Thank you, Dr. Gupta, for joining us.
And Dr. Gupta, we need to talk later because I was just in the iShip executive meeting, and they asked me to ask you if we could hold the iShip meeting in India. So I was literally the whole time thinking of emailing you. It's on my docket here. So I will email you because I was like, yes, I think we should do that. It's going to be in 2023. So I will separately send you an email. So it's so nice to see you in person.
Good to see you too. Yeah.
Zoom. Thank you everyone for joining, and thank you for doing the course. It's really very nice that you guys are doing this. So the question is the use of biomarkers. So my understanding is that the biomarkers are available in India. Is that correct, Revati?
Yes, Dr. Saroj, it's been, but it's not like available in all parts of the country. And maybe we should make it happen. We are thinking of propositions where it can happen sometime, but it is available in some select places, yes.
So the concept is that for all of us to know that, and I don't know whether we'll discuss today or not, but all of us clinicians, when we see patients, sometimes the diagnosis of preeclampsia can be confusing, right? So you have these patients who may have chronic hypertension, who have kidney disease, who have lupus. They may have pre-existing hypertension and pre-existing, for example, proteinuria. So one of the things that early on we and other people have shown is that in women, if you have patients who have, for example, in the third trimester, kind of beyond 24 weeks, come in with suspicion of preeclampsia. And I use that word not any loosely, but women that a clinician is suspecting. So she could have hypertension, she could even have like something simple as edema, symptoms, anything. And the woman is being evaluated for preeclampsia. There are lots of studies now that the biomarker, specifically soluble FIT PLGF ratio, can separate patients who will be at risk to develop severe preeclampsia within 2 weeks if the biomarker ratio is high. And if the biomarker ratio is low, they will be at low risk for diagnosis of preeclampsia, low risk for adverse outcomes. So that's been like shown in lots of prospective observational studies that in women, when you're suspecting preeclampsia, specifically in triage, the biomarkers can separate the patients who are at risk, who are not at risk. So the question becomes, how do you then use this? So unfortunately, in the United States, though I did a lot of studies, the biomarkers are not yet FDA approved. So I'm not using them personally, but I'm helping a lot of companies actually get them in US. But I know a lot of people in Germany, for example, use them, and I know Revati uses them. And one of the ways that people have been really using them is using them in combination with other clinical markers. So you have ladies, for example, you have so we are not saying that you should get rid of all your clinical other assessment tools that you have for evaluating a patient with preeclampsia. But the hypothesis here is what we are trying to say is you can use the biomarkers in conjunction with the other tests that you're using. So whether you have hypertension or whatever you have, and you can measure the biomarkers at the time of initial evaluation, and that will give you a sense of whether this patient is really low risk. So if the patient is low risk, and some of the studies have shown a negative predictive value for prediction of preeclampsia is the CADR of like 95, 99%. So you can be very well reassured that that patient's risk to develop preeclampsia is rather low. And in that case, based on what you're trying to do, you can discharge her home. You don't have to admit her for betamethasone, and definitely you can, safely prolong her pregnancy if all you were trying to do is to say, oh, I'm going to deliver her if her risk of preeclampsia is high. So I think, so that's like kind of one application. The other application would be on the flip side. If somebody's soluble fluid PLGF is high, you can potentially admit them. You can maybe keep them more in surveillance because you know that maybe something bad is going to happen. And at least in the observational studies and other even real world data, lots of studies have shown that if your biomarker level is high, there's a very high correlation with timing of delivery. So if you divide the patients into low biomarkers and high biomarkers, patients with low biomarkers go long in pregnancy. Patients with high biomarkers get delivered because there's going to be something wrong with them. So again, we are not proposing that you use the biomarkers to guide delivery. So there should be no time that you're going to say, I'm going to deliver this patient because her soluble fluid PLGF ratio is X, is 600, 700. No. But if the soluble fluid PLGF ratio is high, eventually the patient will develop some adverse outcome which will make you deliver. So you can keep those patients under close surveillance, give them betamethasone, monitor them more, and use the biomarker to kind of guide your management.
Yes,
Revati, is that good enough, or should I keep going?
Yes.
I don't know how long the answer should.
I know. I think we have about 2 to 3 minutes for a question, and we have another sub-question in the same series. And I think that was a very convincing answer. The next question is this clinical scenario. This is from Dr. Deepa KM. She says, I have 2 women who just completed the first trimester and both have history of severe preeclampsia in their previous 2 pregnancies, treated elsewhere, and ended in either termination at 6 months of gestation in view of maternal well-being because she was not stable, they were not stable, or because of intrauterine fetal demise. They both were on low molecular weight heparin as well as aspirin 150 milligrams. I think they are currently also on low molecular weight heparin and aspirin 150 milligrams. And one of them had APLA screen negative in a prior pregnancy. And she says the uterine artery Doppler study is normal at 12-week scan for one of them, while the other lady's report is awaited. Both have normal blood pressures till now. So any practical pointers going forward? Maybe she's asking about screening and surveillance protocols.
Give me a minute. I actually have a very sick lady. I'm on service, so my resident is calling me. And I was like, I'm on a Zoom. And she's like, it's a late Zoom. And I'm like, yeah, it's international Zoom. So I'll call her back. Yeah, I actually have your question, so I read it. I would say that, so there is application of biomarkers also in the first trimester. So if you follow the ASPRI trial, they used PLGF, uterine artery Dopplers, your mean arterial pressure, and that can give you which are the patients at high risk. Now, this particular patient seems like you are doing everything that needs to be done. So she definitely has a prior history of preeclampsia, but in the presence of APLS negative, I personally do not treat patients with low molecular weight heparin, but it's okay, you can treat them. Some people just empirically treat them. So low molecular weight heparin and aspirin is, in the US, we don't even do uterine artery Dopplers. So if her uterine artery Dopplers are normal, I would say that her risk for maybe preeclampsia in this pregnancy is low. So you can continue her low molecular weight heparin, continue her aspirin. Any patients of mine who have a prior history of severe preeclampsia, I manage them. I mean, I'm assuming they don't have chronic hypertension, so the blood pressures you're saying are normal. Yeah, I give them a blood pressure monitor. So I'm big into home blood pressure monitoring. And I know later on there are questions about postpartum blood pressure monitoring, but I routinely do antepartum blood pressure monitoring at home. I typically don't make decisions entirely based on the home blood pressures, but there's data about this too. And in my practical experience, I've been doing this for over 20 years. I feel like patients' blood pressures at home can sometimes be higher a little bit earlier than they are in the clinic. So you can actually catch some of this hypertension that they have at home a little bit earlier. So obviously education around preeclampsia, home blood pressure monitoring, continuing your medication. And I do pretty extensive fetal surveillance. So I start doing, obviously you do the anatomy scan at 19 to 20 weeks. I start doing growth ultrasound somewhere starting at very early, like 24 weeks, especially in patients who are super high risk. Every 4 weeks, I do growth ultrasounds and start doing fetal testing somewhere around 32 weeks. And if you're lucky and she gets, one kind of, I wanted to say that in my previous question is that there is rationale to follow these patients. And Revati did that study in high-risk patients where you know that the risk for preeclampsia is high. You can also sequentially follow these patients with biomarkers. So we did that study whereby you can follow these biomarkers along the pregnancy, like Q4 weeks if they're normal. And the patients who have low biomarker throughout are actually go to term. And the patients who have high biomarkers or the biomarkers are going up and up with each measurement, they're actually at high risk. So again, no large studies done for recurrent use of biomarkers throughout pregnancy, but a patient like this, I feel like you can definitely measure her biomarkers after 24 weeks, check a soluble fit PLGF or just even PLGF. That can give you some sense of if she's going to develop preeclampsia, then maybe you can increase your surveillance and even design your study a little, like your delivery timing a little bit early. But if no hypertension happens in this woman, you can take her to term and hopefully deliver her at term. But I would just do intense surveillance of the mom and the fetus and not give her anything. Obviously, you don't have to do anything more than your Lovenox and your aspirin.
Absolutely, Dr. Suresh.
I would like to add one point, Revati. Has she told when was the severe preeclampsia? Was the early type or the late type?
No, sir. She's not told us
No,
that.
she just said severe preeclampsia in previous 2 pregnancies.
Okay, because
and then it says,
negative APRA, we have to keep in mind. And
correct.
Yes, sir. Absolutely.
Yeah,
and
correct.
She says
but
one of them is negative.
Them
so
terminated in 6 months. Yeah, so I'm assuming it was really early onset. Yeah, with IUGR seems like it.
And it's like reassuring that the first trimester screening is negative.
If they were early onset, I would empirically start her on HCQS. So that things go a little more smoothly.
The endothelial function is stuck.
Would you do a thrombophilia screen? Because it's
so
and
in patients who have, so in patients who have no history of DVT or PE, I do not do inherited thrombophilia. I just do acquired thrombophilia, such as an APLS workup, but not inherited thrombophilia. No.
Anyway, she has started on already low dose.
Correct. Yes,
so,
which is fine. Yes.
Yeah.
So I agree with you. I mean, there's almost no rationale to do the test because what else you're going to do even if it comes back positive. Correct. So she's already on Lovenox, which, I also am like this. I sometimes empirically treat patients with Lovenox if there is no other answer. I'm like, what else can I do? I'll give you Lovenox and aspirin and hope for the best. So, yeah.
One thing we have found that, we used to think that factor V Leiden mutation is not so common in India, but we have found that is comparatively is common, so at least that one can
be covered by Lovenox, correct?
I think we've had a comprehensive solution to this problem. So we'll move to the next question series, and this is to Dr. Prakash Mehta. Sir, what is the first question what is the role of diuretics and albumin infusions in preeclampsia for a patient who's had ascites or pleural effusion in the antenatal and postnatal period? So there are 3 questions. I'm going to ask you one question at a time so that you can answer sub-questions separately.
Now, basically, we should remember that ascites and pleural effusion with severe preeclampsia is not so common, in the sense the general incidence that has been reported is about 2 to 10%. In my practice, I would say it goes even up to 25% because mine are selected referred patients. So you will come across a patient with ascites and pleural effusion definitely once in a way in your practice. And once there is a pleural effusion and ascites, HELLP syndrome definitely has to be ruled out before we go further. Now, before we say why we are going to give albumin or why we are going to give diuretics, is it useful or not? Let's just quickly go through why does ascites occur in preeclampsia. Now, the basic reason for occurring of ascites is varied. Now, one of the reasons is what is due to the glomerular capillary blockage. It has been found that there is a low kind of a DIC with platelet accumulation in the glomerular capillaries that leads to the leaking of the albumin in the urine. That could be one part. The second part would be that it could be a generalized capillary permeability, what you find in any of the preeclampsias. The more important reason over here that we need to consider is the subclinical hepatic dysfunction. Just as in a cirrhosis patient, we have ascites. Similarly, in a patient with severe preeclampsia, we can expect an ascites because of hepatic dysfunction. The other important thing is that how do we reduce it? Can I give albumin to it? Now, why we give albumin? We give albumin to increase the oncotic pressure. By increasing the oncotic pressure, I am hoping that the amount of transudation that occurs into the abdomen or into the pleural cavity would come down. Now, albumin is reasonably safe in the postnatal period, but in the antenatal period, it could have its own complications. So we need to use albumin with care whenever we are giving it in the antenatal period. Personally, I don't think more than about 5 cases where I have had to use albumin for these patients to bring down, because this patient was with massive ascites. One of the patient had an ascites of 6 liters ultimately. And, she couldn't breathe. She came to me absolutely orthopnic. She had that kind of a picture. So there I had to use albumin, but by and large, in a vast majority of the cases, they generally don't need albumin. Now, similarly, in the post-operative period, if you check serum albumin, if the serum albumin is around 1 gram or 1.5 grams, then possibly you may consider using albumin. But in that situation, I would say diuretics would be a better answer. Now, we all know that we don't like to use diuretics during pregnancy in a preeclamptic patient because the intravascular volume is already constricted, and by giving a diuretic, I may further cause damage, end organ damage could increase. But if there is a pulmonary edema, then definitely I would like to use diuretic. If there is a massive ascites, I would definitely like to use diuretics. But the dose of the diuretic, the close monitoring of the patient is absolutely individualized. There are no set rules that I will give, let's say 20 milligram of a diuretic or a 40 milligram of diuretic. No, I have to individualize on that particular patient. Now, the second important diuretic drug that we can use is the drug aldactone. So this would neutralize the aldosterone, which is one of the culprits causing ascites and pleural effusion. Now, let me tell you, I've had patients who have had I've done a cesarean section. Pre-operatively, the amount of ascites was hardly 400, 500 ml. But post-operatively, the ascites went on increasing. And on day 2, through my incision, she was literally flooding out water. And that water reached up to the door of the ward. So that much amount of fluid she had had. Now, here, let me just break and say that that is why whenever you operate on HELLP syndrome, apart from knowing the intraperitoneal bleed that could occur, drainage of the ascites would also be one of the important aspects, so that in the post-operative period, I've had patients where I put a drain and then the amount of collection on the first day is about, 1 liter, 1.5 liters. And then from next day onwards, it becomes 800, and by third day, it becomes 300 and so on. So in this patient, when we use aldactone in the dose of 25 mg BD, or once in a way, I even have to go up to 100 milligram per day. then the results are very good. So both albumin and diuretics post-operative period for ascites and pleural effusion. Now, quite often when there is ascites and pleural effusion, the oncotic pressure is so low that unless you are very, very careful, you're going to land with pleural pulmonary edema also. So that's one of the reasons why you need to give the diuretics. And when you give diuretics, no giving homeopathic doses, no giving 10-20 milligrams. I've had to go even up to 120 milligrams for a patient. And after giving 120 milligrams of Lasix to the patient had settled down. So I repeat again, we individualize, see that particular patient, no guidelines, no set rules, and you follow up that patient like that.
Yes, sir. So what you're trying to say is that there is no definite role of diuretics and albumin infusions antenatally, but definitely postnatally, you can use it judiciously, is what you're trying to say.
Absolutely.
And the next question,
Revati, can I add something
I want
quickly?
to ask
Yes,
you,
please.
sir, would you?
So,
yeah, Dr. Saroj would like
Yes,
to add a comment.
Sure, sure.
so there was a very recent randomized controlled trial done from UPenn. And what they did, they took patients who had, so obviously what Dr. Mehra is talking about is patients with pulmonary edema who have massive ascites. Obviously, you
Yes.
need to give larger doses of Lasix. But there was a randomized trial done, and which was published in Hypertension Journal very recently in November 2021. And essentially, they randomized patients who had preeclampsia and gestational hypertension into prophylactic Lasix. So they gave Lasix 20 milligrams PO starting within 24 hours of delivery for 5 days. Just prophylactic on every patient who had preeclampsia, regardless whether you had pulmonary edema or not. Obviously, pulmonary edema you treat separately, but this is like patients who are otherwise fine, as long as they're not bleeding and their creatinine is fine and they don't have allergy to Lasix. And what they found was that the postpartum, and I know we're going to talk about postpartum hypertension, what they found was that the rates of postpartum hypertension was much lower and the need for postpartum antihypertensives was much lower. So based on that paper, actually it was an RCT that was published. I can put it in the chat box, the link to the RCT. What we at our institution now, all patients who have preeclampsia, we've written in our protocol that they get Lasix for 5 days. So you give them PO, this is PO Lasix. This is not what Dr. Mehra was talking about, but this is PO Lasix 20 milligrams daily for 5 days. So typically the patient stays in the hospital for 2 to 3 days. So we give it to while they're there and send them home with Lasix PO. So that's kind of part of our routine postpartum management of all patients for preeclampsia. We're giving them Lasix PO. And I can send you that. I can send the link to the paper, the PDF of the paper as well.
Sure.
That will definitely
I think that's definitely worthwhile trying out. But I don't know, in my practice, I've always felt that aldosterone antagonists work much better in this kind of a situation, especially when there is massive ascites.
Yes, sir. So we'll just move on to the next sub-question, sir. Would you consider a dose change for Maxalt in morbidly obese patients?
So whenever we talk of a morbidly obese patient, whether it is anticoagulant or whether it is antibiotic, we know that because of the generalized volume distribution of the drugs, the dose needs to be increased. That's the basic principle in any morbidly obese patient. But as far as preeclampsia and magnesium sulfate are concerned, there have been many articles. There have been even randomized controlled trials with measurements of magnesium levels, and most of the time it was found that if you give 6 grams as the loading dose followed by 2 grams per hour. Now, just to come as a corollary of it, in India, we know we are all the time arguing that our patients are thin and we need to give a lesser dose to them. People have started giving only 2 grams as a loading dose instead of 4 grams. So similarly, if there is an obese patient, you need to step up your dose. There is no doubt about it. But here I would just like to bring out one beautiful statement given by Sibai. What he has said is that the level of the ultimate use of magnesium sulfate is for prevention of eclampsia, not for magnesium level. Just because my magnesium level, which is supposed to reach 4.6 milliequivalents, doesn't reach that level, doesn't mean that my patient is going to get eclampsia. Because most of the time at around 3.4, if you see the secondary analysis of the CLASP study, at 3.4 to 3.6 magnesium levels, the patient did not get eclampsia. So this question is still open to argument. But definitely let us say if we take Indian situation, most of our patients are 50 kgs. Very rarely, I've had patients with 140, 150 kgs also. In them, I definitely step up the dosage. But if you have a patient with 80, 90, 100 kgs, I don't think we really need to change our dosage. 4 grams and 1 gram should be enough. But if they're obese, what I do, I have no backup of really any evidence if you ask me for that. But I give a 6 gram loading dose followed only by 1 gram per hour. Because here we are not used to using 2 grams because we feel it overtreats the patient. And of course, what we need to do is in our situation, we need to definitely measure, as a part of a trial study, the magnesium levels and see how they behave in Indian population. Because all the results are from the Western population and the metabolism of magnesium sulfate, we do not know how it is in Indian population. But to answer it in short, if she is morbidly obese, 6 grams followed by 1 gram per hour. If she is around 100 kgs, I would still use only 4 grams followed by 1 gram per hour.
Okay, so you're telling us that there's no major difference, usually titrated between 4 to 6 grams as loading dose,
Absolutely.
and maybe 1 gram per hour. Okay, sir. So,
and I can tell you that, Revati, we see a lot of obese patients here. So I was just calculating kgs into pounds. So I have patients who have a BMI of 70, which would be like 600 pounds, but that's okay, which would be like massive amount of kilos. But our average patients could be anywhere to 300 pounds, which is 136 kilos. I can tell you I treat a lot of preeclamptics, and I kind of go with what Dr. Mehta was saying. We have a standardized protocol for 6 and 2. So if you load them with 6 grams and then I give them 2 grams as an IV infusion, we do not adjust them based on their weight, and we actually do not measure the MAG levels routinely on patients unless they have renal dysfunction. So obviously, because MAG is renally cleared, anybody who has a creatinine more than 1.1, we measure their MAG levels in that scenario, and sometimes only bolus them, but routinely we do not dose adjust them based on the BMI. But I would agree that perhaps the metabolism of Indian women for magnesium may be different. So that could be something worthwhile studying. If you guys have access to obese patients, you can give them MAG and measure their level and look at the prevalence of some of the complications.
Yes.
May I add something? Can I add something?
Yes, sir, please go ahead.
We are doing, this so-called REVAM study for last 5 years with ICMR. It's ours is one of the center of excellence for that, and done in about now, more than 3,000 patients. So what interesting findings, we are completing the 5th year. This is not as published, but it has been submitted, to ICMR, and we are finding that calcium magnesium ratio makes a difference, in first, second, and even third trimester. And this is going to be very, revealing finding, and where the magnesium has to be kept at a comparatively higher level. We are talking so far only about calcium, but magnesium also does matter. So looking at it, of course, the detailed analysis is going on, but we'll find that magnesium will play a very important role, and if at all, we should use it more and more and not less and less.
Yes, sir. Thank you so much. And it was very insightful to hear Dr. Sarosh Rana as well as Dr. Sanjay Gupte add on that, mostly we should stick on to 4 to 6
Revati, I put that article in the chat box.
Thank
the use
you.
of
Thank
the
you, Dr.
RCT
Sarosh.
for furosemide. It's a PDF, so you guys can download it.
Yes, we will archive it, Dr. Sarosh. Thank you. So the next question is there any role for conservative management in HELLP syndrome, which is associated with extreme prematurity, sir?
Well, if you ask for my personal opinion, I would definitely say no conservative management for HELLP syndrome. But if you go through the literature, go through the various work that has been done on the conservatism in HELLP syndrome, then you find that there is definitely no consensus. For every article you have that says do a conservative management, you have another article which says, oh, look, so much of morbidity, mortality is increased. But if the patient has got what we say, HELLP syndrome is, it doesn't have a very fixed definition. That people with call anything as HELLP syndrome. Even a partial HELLP syndrome is called as a HELLP syndrome and analyzed as one group. So if it's a partial HELLP syndrome, let us say that there is just one of the, whether it's a platelet count or whether it is liver enzymes, only one of them has altered and not all, then possibly we may have a small role in conservative management. But otherwise, let me tell you, my experience has been that sometimes when you wait, even from morning till evening or from evening till next morning, the platelet counts drop from 60,000 to 10,000 and 5,000. And the amount of bleeding that occurs is sometimes quite phenomenal. So unless, it's definitely less than 32 weeks and maybe a partial health, not a complete health. And then I would try after, continuously monitoring her, both mother and the fetus, because IUDs are known to occur when you're conservatively managing HELLP syndrome. Even if you manage to somehow save the mother, the fetus goes for whom you're trying to extend the pregnancy. So my answer would be definite no, unless it's a partial HELLP syndrome.
So what would you, would you attribute something to the biomarkers here? Suppose a lady is in partial health.
By the time the HELLP syndrome comes in.
Not an established HELLP syndrome, sir. I'm talking about one.
A patient whom you have doubt may go in for the HELLP syndrome. Yeah, exactly. Definitely biomarkers. I'll give you one very simple example of such a case. I had one patient with a blood pressure of just 140/90. That is all. And we did a glycosylated fibronectin on her, and to my surprise, it came greater than 600. This was at about 4 o'clock when I was just about to leave the hospital. Somehow, because the biomarker was abnormal, I told my residents that please watch out for this patient, because I can't understand why biomarker is abnormal. And by 2 a.m. at night, the patient started having hematuria. And at that time, her platelets dropped to 30,000, and at 3 a.m. in the night, I had to go back to the hospital and do a section and give her about 6 units of transfusion. Now, retrospectively looking, when the biomarker was so abnormal and she was already 34 weeks, maybe if I had delivered at 3 o'clock, I didn't have to spend my whole night sitting with the patient. So biomarkers are definitely a big yes, because, HELLP syndrome sometimes starts only with the BP of 140/90 or even with the BP of 120/80. And it is only in the post-operative or post-delivery period that blood pressure starts shooting up. So yes, definitely we should use biomarker to identify it. But once HELLP syndrome comes in, possibly the biomarker is already going to be abnormal. Absolutely. So at that time, you decide on your conservative management based on. I think of course, steroid has been used, but personally, I'm not a believer in it. So because it's just a whitewash. It temporarily increases the platelet count, giving you a false security. So I don't use it.
I think very important point made, Prakash, is that, beware of HELLP syndrome. If it's HELLP syndrome, don't go for, conservative, and not
absolutely
when you're
absolutely
even after delivery, sometimes you deliver and you say, okay, now she's going to improve. She may worsen for next 48 hours, and be very, very careful with these patients.
No, I'm definitely learning the hard way, and I don't want any of our youngsters to, do this conservatism unless, as I told you, maybe one parameter is abnormal. You can still monitor her very closely and continue. But if all are abnormal, no conservatism.
Absolutely.
I agree with that. And can I add something? And again, this is not out yet, but we did add, and when I know, Dr. Mehra, when you say biomarkers, maybe you're talking about different biomarkers, but at least the angiogenic biomarkers, we just added them to the definition of preeclampsia in the new ISHIP guidelines. So we just wrote the new ISHIP 2021 guidelines. And I think Dr. Mehra, you were part of it, or Dr. Gupte was part of it, right? Dr. Gupta, you were part of it. Yeah. So we added biomarkers along with all other things. So you can be hypertension plus biomarkers, hypertension plus LFTs, whatever. So biomarkers are kind of equal weight as other, clinical signs of preeclampsia. So I do agree that, perhaps down the road, like Dr. Mehra was saying, you have somebody at 34 weeks who has mild hypertension, but her biomarker is really abnormal. You can potentially make a diagnosis of preeclampsia in her case and move on with whatever you were trying to do in terms of, managing her expectantly or not. So I think more and more, hopefully once these guidelines are in place, and hopefully you guys will use them, I think that will give us even more kind of, almost reassurance to deliver her, even with like mild hypertension when she is not like in full-blown HELLP and then you're chasing the DIC. So I think that will definitely reduce some of the morbidity if you use the biomarkers correctly.
Absolutely.
At the same time, I should tell sometimes how the biomarkers could help us in screening out also of these patients, because I've had patients with elevated liver enzymes and mild
and her soluble FIT PLGF is 2. Exactly. So if her soluble FIT PLGF ratio is like normal or 2 or 3, then you can say, well, her transaminitis is from something else, probably not related to preeclampsia that we.
Autoimmune hepatitis
Yeah,
is one of the
absolutely.
commonest
Absolutely,
conditions that we come across. So in
Correct.
those cases, it's fine.
And you will come, you will reduce the burden of iatrogenic prematurity.
Can I say something? Just
Yes,
one.
please.
Yes, Dr. Prakash, you were telling about glycosylated fibronectin. We have done a study on all primary gravidas who are hypertensive and who are not hypertensive. And we have seen those patients who are severely hypertensive, the glycosylated fibronectin is always on the higher side. And those who has shown a lower level, I mean, a higher level of glycosylated fibronectin, they do develop hypertension in the later part of it. So I think this is also can come as in some kind of biomarker for the development of preeclampsia, and it's quite helpful in that particular study that has come up.
Absolutely.
So quite helpful.
Okay.
You know, sometimes it takes away the guilt from you that I'm delivering a patient at 30 weeks. Am I really doing right thing?
Thank you so much, sir. I think we're running out of time, sir. We have about 10 more minutes.
Yeah, we'll quickly. How many? Two more?
sir. Yes, sir. So the next set of questions is to Dr. Rana. What is the best antihypertensive to start with postnatally? Is it levodopa or amlodipine, or are there other antihypertensive drugs to be considered? This question was put by Dr. Devani and Dr. Sahana P.
Yes, so I know you had 2 and 3 other sub questions in there. So
Correct.
I will try to answer this one short because I can maybe share my screen and then answer the other 2 questions with 2 slides.
Sure.
So the short answer is no, there is no difference between labetalol, and we typically use labetalol and nifedipine as the first agent of choice. I think there is some data that perhaps blood pressure control may be a little bit better with nifedipine. So, and it's also a one-time drug. So personally, in my patients, I always start with nifedipine unless the patient has like headache or some other thing from a rebound headache. It could be possible, but I typically do start with nifedipine first. If the patient is not breastfeeding, I'm a big fan of hydrochlorothiazide kind of a thing, or even ACE inhibitor, because I just really want to control the blood pressures postpartum. But most of my patients do breastfeed. So we either do nifedipine and add a labetalol second agent, but I think most of the time you can just be fine with one agent, and I typically start with nifedipine. So that would be my answer.
So I would ask you the other 2 questions.
Could I just
Yeah, go ahead, Dr.
If there is tachycardia, I prefer using beta blocker in the post-operative.
Sure.
Absolutely.
If
Yes.
there is the heart rate is normal, then I prefer amlodipine.
Absolutely, sir. So I think the answer is quite clear. So it could be either of the 2, and depending on the clinical conditions, you can always choose your antihypertensive. The next question is, what is the protocol for long-term follow-up of cardiovascular and renal function in women with preeclampsia? Please elaborate on the frequency and duration of monitoring. And I think Dr. Rana wants to take the next question as well. And the question reads as, kindly elaborate regarding the monitoring of blood pressures in a preeclamptic woman post-delivery. Is there a role of patient education to ensure better compliance for follow-up? So the questions were asked by Dr. Akshaya Murali and Dr. Sahana P and Dr. Uzma Sultana. Dr.
So
Saroj,
I
do you
will
want
just
to share your screen.
So this is yeah, so you guys can see my screen.
Should I stop sharing?
Oh, I think you guys can't see my screen.
Yeah, it's seen, it's seen.
It's seen. Okay, yeah.
Okay, so answer your first question. The last question first is, what is the long-term follow-up? So this is a very recent review article that we just wrote in Hypertension. And again, I can attach this to the Zoom link if you want to archive this. But essentially the way we are proposing is, there is this immediate postpartum, which I can maybe show one slide, but there's a massive role of education in there. We have a whole educational program around it, which is also published in Green Journal. I can share that with you guys too. But essentially you need to do hypertension follow-up according to your national guidelines. So for example, here in ACOG, they say that postpartum, you can start antihypertensives when your blood pressures are 150/100, at least, because they don't have to be severe, similar to what you have to do antepartum. So you can start antihypertensive at a lower level, and then you maintain your blood pressures like anywhere between 120 to 150 over 80 to 100. And I typically try to manage my blood pressures a little bit. I follow the AHA criteria postpartum, which is really 120/80 is normotensive, 140/90 is actually already stage 2. So if the person is normotensive, you go to the next steps, which is, so typically you should have this management of immediate postpartum, and then you do the 6-week postpartum visit, which happens with the OBGYN. But we are suggesting that perhaps in the first 3 months, so in the 12-week postpartum, you can have the patient be assessed for her cardiovascular risk, either by a primary care doctor or by a cardiologist. And it's not very extensive, but a simple risk assessment based on her smoking status, her physical activity, her blood pressure, and her BMI. And based on those risk assessment, maybe we can suggest some lifestyle modifications. So there are no randomized large trials done, but this kind of approach has been used, for example, in Netherlands and other countries, but also in non-pregnant patient, in an elderly man. This is what they will do. They will start with lifestyle modifications, such as you can, modify their dietary intake, advise them on physical activity, obviously smoking cessation, adequate weight. So that could happen kind of pretty early in your postpartum, so in the first 3 months. And then based on that assessment, we would recommend that all women who have a history of preeclampsia should have yearly postpartum CVD risk assessment by either a primary care doctor or a cardiologist. And here they should get their history, their blood pressure, their lipids, and their glucose. So essentially what we're trying to see is if there are any modifiable risk factors in her state that you can perhaps modify it. So if she has hypercholesteremia, you can treat that. If she's diabetic, you can treat that. So you keep doing that yearly up until she reaches 50 years of age. And that's when most of the American Heart Association guidelines kind of kick in, where you do this like extended risk scoring and lifestyle modification and need for therapy. So this is kind of a newer concept even in the US, is that for all women who, because they're such high risk to have cardiovascular disease, you should have kind of an early assessment by a primary care doctor and then yearly assessment up to the point that they reach the age when your standard cardiovascular risk assessment will come in. And again, I will remember to attach these papers to while Dr. Mehta will talk about the next topic.
Thank you so much.
Now, in terms of your other question, what is the role of education? So again, I'll attach this. This is a Green Journal article that we just wrote. So we actually started a massive postpartum hypertension education program at our hospital because we found that management of postpartum hypertension was very bad. And the follow-up patient was only about 30%. So only about 30% of our women were actually coming back for our postpartum appointments. So what we did was we started this program, we're calling it STAMP hypertension, which is systematic treatment and management of postpartum hypertension. And essentially the patient's journey is that at the time of delivery, I actually created an educational video. It's on YouTube, it's free to download. Every patient has to watch that. And we are giving them written instructions about preeclampsia at the time of their delivery. When they're being discharged, I physically created, and the paper actually has supplemental material, which is all free access. I created protocols for management of blood pressure starting from the time of delivery all the way till 6 weeks. So we manage the patients inpatient, and I can show you a quick protocol. It's very simple. It goes something like this. So if, for example, like this. So if you have mild hypertension, this is your goal blood pressure. If you're chronic hypertension, you discharge them. If it's mild gestational hypertension, what do you do? Severe gestational hypertension, what do you do? So we all know this as physicians, but I can tell you that different physicians in your group practice is practicing differently. So what we did, we standardized all these management protocols, and then we started giving them blood pressure monitors. So every patient who delivers at the University of Chicago and has hypertension gets a free blood pressure monitor I wrote for grants and I got it. And I'm giving them free blood pressure monitors to every patient. We are actually giving them this written log where they would log down their blood pressures, and we have electronic medical record that they can send their blood pressures through that. But very recently I got funded, and now I'm doing remote patient monitoring. So all my patients go home with the Bluetooth monitor, which connects them through the EMR, and we can continuously monitor their blood pressures. Then we schedule the appointment for them so that they can come back at 7 to 10 days postpartum. And this is run by our nurses essentially and by physician assistants, not run by the doctors, where they come in and we do them actually now through the telehealth. So they just like report their blood pressures and we ask them about what their blood pressures are and if they have any symptoms. If the patients have severe hypertension, we have protocols for them to be directly admitted to labor and delivery. And then I also kind of improved upon the readmission. So all readmissions to the hospital for blood pressure goes to maternal fetal medicine, and they're admitted directly through labor and delivery. So we kind of have this continuous process of this journey that the patient goes through. And then we kind of, at 6 weeks, we hand over their care to cardiology or to the PCP.
I think
I'm
that
going
was
to
very
stop there.
comprehensive. Yes, Dr.
Yeah,
Sarosh.
and I can attach those papers while you talk.
Yes, I think we
I
would
think
share
that would
these
be
links to
helpful.
everyone
That
on
would be
email. We're
helpful
going
to
to email.
everybody.
Absolutely. We're going to send this as take-home messages to everyone on email. And thank you so much for those comprehensive answers, Dr. Sarosh. The next set of questions is Dr. Prakash Mehta, sir. Should aspirin be stopped once? I think I'll ask all the questions, sir, because most of them, revolve around aspirin. And the last one is something different so that you can answer all of them together. So the first question is from Dr. Rukmini Balasubramanian, and she asks, should aspirin be stopped once preeclampsia is diagnosed? The second question revolving around aspirin is, what is the dose of aspirin for PE prophylaxis? I think it is PE prophylaxis in patients conceived through IVF. Should aspirin be stopped after cardiac activity is established in IVF pregnancies? Dr. Anjali, this is by Dr. Anjali Jasawat. She again asks, should aspirin be stopped in cases with subchorionic hemorrhage? How do you want to risk modulate these patients if they are already at risk for preeclampsia? So these are questions on aspirin, sir.
Okay, I think I'll be quick because we're running out of time. The first thing is, should we stop aspirin once patient develops preeclampsia? My answer would be no for that. Although FIGO in their guideline has said that you stop aspirin at the time of delivery or if the patient develops preeclampsia. I think that's where that sentence seems to have caused confusion. But remember that we are using aspirin not just for prevention of preeclampsia, but also other reasons like an FGR, like a preterm delivery, avoiding of preterm delivery. Number two, being a COX inhibitor, aspirin can result in vasodilation. And number three, it also prevents aggregation of the platelets. So keeping these factors in mind, the preeclampsia has already come in, but I might be able to prevent the worsening of that preeclampsia. So unless I'm planning to deliver her, I'm definitely going to continue aspirin. So that answer is short. The second one is, in an IVF pregnancy, should we stop aspirin the moment the cardiac activity comes in? Now, please remember that IVF itself is an indication for aspirin therapy. I think Madam Sarosh will tell us that ACOG in 2021 has added it as one of the indications for starting aspirin therapy. And the patients who require IVF quite often are having some kind of an immunological basis also. So in an IVF patient, please do not stop aspirin, because mainly the reproductive medicine specialists use aspirin to increase the endometrial receptivity. But apart from that, you need to worry about preeclampsia also. So we need to continue the aspirin throughout. Okay, the third question was, I think, about the subchorionic hematoma. Now, there has been no evidence that aspirin causes an increase in the bleeding of a subchorionic hematoma. Yes, there have been some articles definitely which say that the amount of accidental hemorrhage or a postpartum hemorrhage could increase. Again, articles on either side. If I have one article supporting it, I have one article opposing it also. But on the whole, if it's the first trimester a subchorionic hematoma, I would still go ahead and continue using the aspirin because again, subchorionic hematoma may be a part of placental dysfunction, and aspirin may help me to improve the placental dysfunction. Or it could be due to some kind of an immune background, which we are not able to identify, and aspirin may be able to help us in that also. Now, coming to the last question, what is the dose? I think the confusion occurs because we have 75, we have 81, we have 100, and then we have 150. Now, American College very specifically says you use 81, which is not available to us in India, so we are using 75. PIGO says use 150. Ranscock says use 100. Okay, but by and large, it has been found that there has been no randomized controlled trial between 75 and 150. Aspirin study came in with 150 milligram of aspirin, but aspirin did not compare 150 to 75. Aspirin used only 150 and compared with the preeclampsia is developing or not. So we don't have any proof that 150 is definitely superior to 75. Yes, some articles have come in that maybe 75 just opposes COX-1, Whereas if you use 150, both COX-1 and COX-2 are neutralized, but we still don't have proof for it. Our women are a little small again, and so I would continue using 75 milligram in our women. Although, as I repeat again, FIGO says 150, ACOG says 81, and 75 and 81 is not much different. Both are almost absolutely the same.
Yeah, I can tell you in
Sir.
US. Yeah, so I can tell you in US, the current ACOG recommendation are using aspirin from 12 weeks onwards. So typically you start between 12 to 16 weeks, but you can actually start it as late as 28 weeks if you don't find the patient in the first trimester. And then you go till delivery. So they very recently changed it. They were saying stop it at 36 weeks. But but now they're saying go till delivery. And I can tell you the reason is because what ASPRI trial showed that, if you listen to Dr. Leona Poon, is what ASPRI trial showed us is that it moves the gestational age of delivery forward. So a lot of people feel that if you stop it at 36 weeks, you'll have lots of term preeclampsia. So now ACOG is also saying you start it and you never stop it. You just keep going till the patient delivers. And I would agree with Dr. Mehta's first assessment too. In my patients, if they develop preeclampsia, if they have chronic hypertension, I'm giving them aspirin and they develop preeclampsia, I do continue the aspirin to prevent from other things from happening. So I do continue, aspirin even in patients who develop preeclampsia on aspirin. Yeah.
Absolutely. Sir, I also want to add on one sentence. Is that if there is an APLA positive patient and she's had a clinical bleed and she also has a subchorionic hemorrhage, she still gets the benefit of low molecular weight heparin when the subchorionic hemorrhage is in CO2 and maybe that doesn't worsen and she carries her pregnancy through, and you can get back the aspirin because she's still protected about say 65% of the times or about 50% of the times without aspirin. So we can actually use alternative strategies in case we're not using aspirin to modulate these patients.
Yeah, I agree with you, Revati, but possibly the question was meant for a general population, because you're using aspirin prophylaxis in general population.
Absolutely.
But if you have an autoimmune background with, that's exactly what I do. With an autoimmune background, I change it to heparin rather than continue with aspirin.
Yes. So the last question is, discuss the availability and costing of the biomarker tests, the SVIT1-PLGF and glyphin in India. This was by Dr. Aparna Kaditota.
Yeah, see, Roche is marketing split PLGF. They have been generally giving it in 48 to 72 hours, but I've been promising that they can give you the result in 24 hours. The cost roughly works out to 2,500 to 3,000 rupees, which is nothing compared to the amount you would spend if the patient develops preeclampsia and needs hospitalization. The second alternative that we have and which I personally use is glycosylated fibronectin, which is a point of care test. It's a very, very simple test. Exactly, you just take a drop of blood and within 5 minutes, even in the middle of the night, even with the junior most nurse doing the test, you get your result. And if the value is above 600, then you know that this patient is going to land up in trouble. The cost of this test is roughly 1,000 rupees per test. That is per strip costs you 1,000 rupees. The equipment costs about 85,000 rupees, which can be used over and over and over again. So basically, I would consider the cost as, so if you add a little bit of instrument cost, maybe 1,200, 1,300, a glycosylated fibronectin can be done. That's very easily available in India. You can do it even in a primary health center. You can do it in the smallest of the nursing homes. You don't need any high-tech equipment. You don't need anything. So possibly for our country, especially in periphery, glycosylated fibronectin could be an alternative. I've already done, or rather my students have already done to the dissertations on glycosylated fibronectin, and our results were exemplary, including the case I told you who just came in with a BP of 140/90 and had a abnormal glycosylated fibronectin. So everything is available. We need to just fine tune our mind that yes, this test needs to be done. Yes, when you can save a life of a patient, 2,500 or 3,000 rupees is not a big sum.
So, and recently we had a discussion with Roche, sir. They want to make it available in multiple places. And if the takers are many, definitely the
sure
cost.
even they'll bring down the cost, because they've been telling me also that
cost
they'll
will
bring
definitely
it down
come down. And incidentally, they're thinking about, converting Bangalore or Bengaluru as a pilot, where they would want to make it available at many places and see how they can help us with optimizing the cost. So I think we are looking forward to it.
Yeah,
So that,
absolutely.
you know,
And
more.
if you're not looking at S-split PLGF, supposing you don't have that facility, then if you're doing only PLGF, then if you have an Abbott machine, PLGF can be very easily measured again bedside. But it measures only PLGF, not S-split PLGF. So
Yeah,
now
hopefully
we know
Roche can.
Dr. Sarosh is here that S-split PLGF is
Yes.
much better
Yes,
compared
sir.
to
Actually.
only PLGF, especially
Yeah, and we've looked
Absolutely,
at that.
absolutely. Yes.
Yes, and I think it just like approximates the outcome, because PLGF can actually be low for a very long time. So
Yes.
PLGF is a good test in like the first trimester screening, because then if it's low, it's like the patient is at high risk. But PLGF goes low weeks to weeks before, many weeks even
prognosticate.
before your adverse outcome is happening. So I think soluble FLIT goes up quite proximate to an adverse outcome 1 to 2 weeks before. So I feel like the ratio kind of gives you this indication that something is imminently coming. Yes. At the same time, I can tell you that the Roche assay, and again, I don't do them clinically here, but in Germany, for example, they can be done in 20 minutes. So hopefully they can actually reduce the turnaround time for you guys, and obviously reduce the cost as well. I think if more people are using it, that's a, and there's so much data, Dr. Mehra, around soluble FLIT PLGF. We're actually working with several different companies, me and Dr. Karamanchi, to going to the FDA, and hopefully we just finished a very large study in US, 10-site study called PRACES, which hopefully will be published soon, and we're going to send the data to FDA. So I'm really hoping with, and especially with iShip putting that in your in the definition of preeclampsia, I'm really hoping that this test becomes like really available to all our clinicians who are, you know, very astutely trying to figure out what to do with their patients. Yes.
I think times have definitely changed. 5 years back, people would turn around and ask, biomarker? What biomarker?
Yeah, I
So
know.
from that on, we have now moved on to which biomarker and when.
Which biomarker and
absolutely.
when to use them. Exactly.
So I think it's a good progress.
They are open to coming and collecting the samples from their clinics.
Absolutely.
So I think we can make a difference to our patients.
Required because our maternal morbidity and mortality, believe me, every week I see at least 2 or 3 patients which could have not gone into those complications if biomarker was available.
I think we've finished with all the questions. Do we have time for 2 questions for the open house, sir?
Maybe you could give them 1 question for the open house and let the candidate only answer. Another candidate could answer the question. We'll just kind of support in the background.
I have time. I mean, I just have to sleep after this. So if, whatever you guys want. Sure. Yeah, no
All
problem.
right, let's make it 2 then. If Dr. Sarosh is
willing to
sacrifice her health, definitely, her sleep rather, definitely.
The first question is from Dr. Vimarshita.
Can you unmute them and ask them to on their video?
Manasa, can you just ask Vimarshita to come on, please? Let her put our video on. Her question is, kindly elaborate on the role of biomarkers like ADMA and placental protein 13 as a predictor of preeclampsia. Is it still at the level of research or approved to be used clinically? This is what Vimarshita wants to ask.
Who's going to answer? Let one of the candidates first answer.
Vimarshita, would you want to...
Then we'll put it to Dr. Sarosh after that.
Yes. So Vimarshita, would you want to tell us your point of view on this question?
Yes, madam. That is
and introduce yourself, Vimarshita. Where are you from? And
I'm Dr. Vimarshita, Assistant Professor, Department of OBG from Sri Devraj Aras Medical College.
Oh, that's Kolar, right?
Kolar, yes, ma'am.
Yes, in Karnataka. Yes.
Yes.
Thank you. Yes.
Ma'am, I just want to know whether it is still at experimental level or we can use it clinically.
Dr. Sarosh, you want to answer this question?
What, PP13 or what?
Yes, placental protein 13
as well as placental protein 13, madam.
Yes, so we do not have, ACARC does not recommend using any of these in risk stratification. So kind of US is a little bit behind, and I'll have Dr. Mehra answer what he's doing in India. So ACARC doesn't still believe in first trimester risk stratification, which is like really bad thing. I think if you really want to stratify your patients in early pregnancy, you should go with what the ASPRI people are saying. You measure your PAPA, your PLGF, your MAP, and you do your uterine arteridopters. I think those have been really studied very rigorously and should be used. And they're recommended by NICE guidelines in UK. They're actually used all over Europe. So I think if you really want to stratify your patients and you find them in the first trimester, I would highly recommend using like PLGF, and then uterine artery Dopplers and map blood pressures. I don't think that PP13 or anything has gone anywhere in any guidelines or any clinical use.
We
As
don't
far as
have
I
enough
know.
I
studies.
think Dr.
Absolutely.
Vimashita asked this question because in Devaraja's Medical College, they have a biochemist who's doing a lot of work on this and has published quite a few papers. I had an occasion, I had a meeting with him also once, and he has been doing this and they have found it to be but it's in a very, very early stage, not yet to come into the clinical practice.
Only most
But he's
studies.
doing a lot of work and very innovative. I mean, I was really impressed by the way he was describing his study.
Sure. I think we got the message that they're still
Thank
not
you,
time
ma'am.
tested
Thanks.
and we need more studies to standardize whether we can actually use them. The second question is to Sir, to Dr. Prakash Mehta, sir. How can we prevent acute kidney injury in a preterm or a term patient who is presenting with imminent symptoms? This is by Dr. Kumari from JIPMER.
Okay, see, AKI can occur in any of the preeclampsias, especially if it's associated with accidental hemorrhage. Point number one. Point number two, the fluid balance is of utmost importance. Quite often we are so scared about getting a pulmonary edema that we tend to underhydrate them. Now remember, already the blood volume is grossly contracted, and if you underhydrate them, then obviously the kidneys are going to suffer even more. So what I would do is definitely monitor her very carefully, give her adequate hydration. I would use the IVC collapsibility to identify how much of fluid I need to give it to her. And if there are already signs of elevated creatinine, I would consider this person as a candidate for plasmapheresis. So that once you do the plasmapheresis, automatically the further AKI can be prevented.
So what you're trying to say is basically it's a continuation of what damaged preeclampsia or the endothelial dysfunction that is happening. So once you're treating preeclampsia,
but a little more aggressively, monitor a little more aggressively.
But make sure that the hydration is
input-output chart to be a little more aggressive.
Absolutely.
And let me also tell you that there are, remember, in preeclampsia is not a single disease. It's a syndrome. It has got multiple etiologies, multiple
organ systems
outcomes that come out of a preeclampsia. So I've had patients where in spite of all care, still the patient lands up with an AKI. I've had, maybe once every 2 or 3 months, I land up with such a patient in spite of all care, still AKI comes in. So that's why it is very important to counsel your patient with severe preeclampsia that she can land up with kidney injury, she can land up with dialysis. Okay, the other important thing we should never forget is that there are many CKDs, especially in India, which are not diagnosed before. In India, somehow we don't do a kidney scan when we are doing a preeclampsia scan. So I always tell that when you're doing an obstetric scan for a preeclampsia patient, please look at gallbladder, look at spleen, look at kidneys, look at adrenals. Because then I would have known that there is a little bit of chronic pyelonephritis in this patient. It's a shrunken kidney, I would have known. So possibly if the patient presented a severe preeclampsia, and the renal failure came in because the kidneys are already compromised before even the pregnancy came in. So look out for that. Do a scan so that you're sure that the kidneys are normal. Okay, look at the gallbladder. I've had patients with Epstein's anomaly coming in to me referred to me as a case of severe preeclampsia. And most of our labor rooms are a little dark. Labor room is generally in one not so good corner of the hospital. I'm sure Sarvesh has worked in India, must know that. And, she was grossly cyanotic, which I realized after she had a normal delivery within half an hour, she landed up with me. And then I realized that she has got cyanosis. And later on, we found that the congenital heart disease was the cause of her, high blood pressure and superadded preeclampsia rather than preeclampsia itself. So there are always surprises. Keep them in mind, especially when you have AKI. And other important thing is never ever use NSAIDs. Quite a few of our doctors have a habit of using NSAIDs in preeclampsia patients, either antenatally or quite often postnatally to bring down their postoperative pain or some such thing. Please do not use it. You don't know when the kidney will get tilted into AKI. Sure, sir.
So what you're trying to say is please treat preeclampsia, look at the fluid and electrolyte balance, make sure you map the kidneys, if you're suspecting preeclampsia. So I think we had an extensive discussion revolving around biomarkers, aspirin use, role of diuretics, postpartum hypertension, patient education. We've also looked at, acute kidney injury and things like that. So I think it was a wonderful session. So we are going to archive all.
No, we have to thank Dr. Saroj Rana again because she has had to miss her sleep.
Absolutely. Thank you so much, sir. Thank you so much, Dr. Saroj. And now I think it's the dream come true moment in a short while. Before that, we would want our co-chairs who've made it happen. So I call upon Dr. Saroj Rana to address the gathering regarding PENAI so far. And then we will also call Dr. Prakash Mehta to give his point of view. Dr. Saroj Rana, can you please give us a few lines about what you feel about the course so far?
Yeah, so thank you very much. I was just going to say, I'll give Dr. Mehta the first chance to talk.
Absolutely.
Go ahead, Dr. Mehta.
Okay. It was more than, I think, 15 years back when Revati and co would come to me as fellowship students, and we would sit and discuss things, and I would be moaning and groaning all the time that, look, we have a pathetic state of maternal fetal medicine in the country, and preeclampsia is not at all managed well. And, those kind of discussions, and almost in every class, at the end of the class, for 10-15 minutes, this kind of discussion would go on. I think Sunita was there, Dipti was there, Chaitra was there. So we would all the time keep discussing regarding this. And I should say that the whole lot of students took me very seriously, and the Society for Maternal Fetal Medicine of India came into existence, and then hard work put in by the entire team, more so by Revati, and we started this PENAI program. Now, I had a lot of trepidation when I started this program. I said, will it succeed? Will it not succeed? There are so many programs, and in between COVID came in, and we were worried whether people would really join for the program. How do we handle the various faculties all across India, across the world, who have taken part into the program? But I'm very happy to state that all our faculties were extremely cooperative. All our youngsters in the society worked very, very hard. And Revati, sometimes I tell her, I said, Revati, it looks you're existing in this world only for preeclampsia, nothing else. So that much of hard work went into it, and we were very lucky to have support from, as I already told you, Mansa from Medinet, listen to every whim, every complaint, immediately correcting it. And of course, Roche, without whose initial push, we couldn't have gone ahead at all. Now with this, we have a big batch, completing the course today, and we are hoping that the next convocation that we have will definitely have at least 100 candidates, because there are 250 people who have already registered for it. And we are in discussion with Roche. We are in discussion again with Dr. Saroj. Revati has been talking to you about it, to spread across the other parts of the world also. We could modify the program a little bit for that particular part of the world, and we go ahead. Our aim has been only one, to bring down the maternal morbidity and perinatal morbidity and mortality with this easily preventable condition, if you really work on it. Not use it as one of the patient of the 100 standing in the line for your antenatal care. You need to give a special care to this preeclamptic patient, and she will survive, and her baby will also survive. So thank you all once again for being a part of this program. Dr. Saroj, please.
Yes, so thank you, Dr. Mehta. I would echo that, and thank you. I would agree for all of you guys, and to be able to attend this program. Now, I can tell you a little bit of my history. Is I don't know, Revati, when was the? I mean, and I have to tell you, like, I feel sometimes I live in this world just to, my dream is to treat women with preeclampsia. So I think you obviously need that kind of passion behind you. But it was a long time ago when I met Revati in one of the meetings, and it's been like nothing but such a pleasure to work with Dr. Mehta and Dr. Revati. Obviously, wouldn't have been possible. I mean, I'm kind of busy myself, but these guys are just amazing. So yeah, I think, in my mind, I feel like I can just treat one patient, treat two patients, but this is amazing, right? Because then we can, give some knowledge to you guys all, and then you go out and treat 100 more patients, and then hopefully you can tell more of your colleagues to get this education. So I think, and then even, you know, now you have this knowledge, so you can give it to your nurse, you can give it to the next person who comes your way and say, hey, you know what, this is how we're going to treat preeclampsia. And I do agree, a lot of morbidity from preeclampsia, actually there are studies done here in US that as much as 70 to 80% of the morbidity happens in preeclampsia is preventable. And it's preventable by knowing about the disease, by adequately treating it, by finding it early, and managing both mom and baby really, really carefully. So I would say thank you so much for joining the course and completing the course, and please spread the word around. I mean, yeah, our dream is to like really educate every physician who's out there, definitely starting with India, to tell them how to, you know, and then we can redo the courses. I'm hoping that we can like add some new information as it comes along. You know, any new protocols that are being published or any new papers that are coming along. But yeah, so thanks for doing the course. I think this is amazing.
Thank you so much.
Dr. Sarosh, I should tell you this, we are coming out with a bridge course for the corporation doctors because they say they wanted something to be done within only 4 hours. So we are doing the course for them. All our society members are already working on it. We have Dr. Asha, Dr. Chaitra, Dr. Sunita, all are working on it to make a shortened course from whatever we are doing. We also have a course for Ayush doctors. I mean, in case Ayush doctors are the doctors who don't do allopathy, but from Ayurvedic, homeopathic, Unani group of people. They do treat pregnant patients. We were in a great dilemma whether we should you know, have a course for them or not. But then they also treat the pregnant patients. So we thought we should modify it in such a way that we tell them how to identify complications, when to refer, how to refer, so that again, the morbidity, mortality due to late referrals comes down.
Correct.
So as I told you, sometimes I really wonder whether Revati's got a family, a practice or what, or she's doing only pre-eclampsia.
Sir, thank you for, I mean, both of you for being my inspiration. And we are also thinking about the virtual learning series on preeclampsia, which we're going to do it, I think, every 4 to 6 weeks to include faculty from across the country. And we're also going to talk about PENAI and take PENAI across the country. And this is the money that is going to be raised through this is going to help us fund courses for these government doctors, because at the grassroots level, these are the doctors who are actually looking at the preeclamptic women, and we definitely want to make a difference to them. We're trying to raise funds to help educate these doctors. So I think it was a very emotional moment for all of us, because it's like an email turned into reality today. So with this, we have the most coveted moment, the virtual convocation. I would request Dr. Prakash Mehta sir and Dr. Sarosh Rana to kindly inaugurate the convocation, and I would read out the names of those successful candidates who are passing out. It's been a tough task. They've managed a 75% score, and those who've not been able to do it have been given another attempt. And you know, finally, they've all managed to score with distinction, which is very, very you know, precious and is well appreciated. So I request Sir and Dr. Sarosh Rana to inaugurate this session now. Yes, so I'm reading out the names of those candidates who have graduated. We have Dr. Akshaya Murali, Dr. Vimarshita P, Dr. P. Saunya Singh, Dr. Aparna Kaditota, Dr. Deepthi TL, Dr. Sahana P, Dr. Aparna Setia, Dr. S.K. Nadeem Hussain, Dr. Rukmini Balasubramanian, Dr. Devani Chalumuri, Dr. Anjali Jasawat, Dr. Kumari Paneer Selvam, and we have Dr. Savita Chennur. We also have Dr. Uzma, Dr. Asha, and Dr. Deepa, who will finish the assessments very soon, and they are almost in the verge of graduation. So we have almost 16 people today who've been part of this big list. So this is how their certificate is going to look like. So congratulations, all of you from the Society for Maternal Fetal Medicine India, as well as the International Society for Study of Hypertension and Pregnancy and the PENAI core team. So we always feel a good education is a foundation for a better future.
Yes, congratulations, everyone.
Congratulations, everybody.
So with this, I would want to thank.
Before we go further, Revati, could we ask, there are two teachers definitely with us over here. Dr.
Absolutely.
Jyotika is there and Dr. Shashwati is there. Could we just ask them to give a little bit of input from their side? Dr. Shashwati, please.
Yes, I think this is also, when I was hearing both of you, it was also one of my dream, because the Assam being the northeast corner of the India, yeah, we have a very, very high maternal mortality for wrong reasons. We are famous because we have the highest maternal mortality. India has 103, but we have 205. And out of that, almost 28% would be for the hypertensive disorders of pregnancy. So I really wish everyone to have the knowledge regarding this. And I congratulate all those participants who have successfully, they have gone through this program, and so that they do good for and I wish more people from the Eastern region, they take part in this particular program. Thank you so much.
Dr. Jyotika, please.
Preeclampsia has always been like an enigma to me. And when Prakash and Revati thought of starting PENAI, I was very happy to have been a part of it. Thank you, Prakash. It was an eye-opener because there are so many things. It's like the iceberg, we only know the tip. We still have to know 7/8 of it. So we'll keep learning more and more, teaching more and more people so that at least, in our country, we'll be able to manage preeclampsia in a better way. Thank you very much for making me a part of it.
Thank you. So Dr. Asha or Dr. Sunita from the coordinators group? Dr. Asha or Dr. Sunita?
Yes, sir. Sir, thank you very much, sir. Thank you, Dr. Revati, and thank you, Sarosh Madam, for allowing us to be a part of this whole PENAI course. It was a wonderful learning experience, even for all of us. And actually, this has motivated us to become more research-oriented. We are always clinically oriented. Each case comes, we try to manage it. Sometimes we are lucky to manage it the right way. Sometimes we may not be so lucky. But this course has definitely been has become an eye-opener to all of us to become more research-oriented. And as Sarosh Madam rightly put, so many articles and RCTs and all that. So this will definitely help us to become much more, with better learning experiences. Thank you. Thank you, sir.
And I can tell you that a lot of work, like for example, this postpartum hypertension, are like the quality initiatives which you can think of. You can obviously take what's I have written, or just think about the things that you're commonly practicing and what your organizations are telling you or what you're doing, and systematically put that in place. So the way that I personally feel is especially if you're working in large organizations. So for example, I work in a large organization. The way to combat this disease is kind of hashtag every patient every time. So you have to treat the person the same way. It's not that if you are in the hospital, her blood pressure is managed. If somebody else comes along, her blood pressure is not managed. If you're busy, the blood pressure is not managed. If so I think some of these, if you standardize the protocols, and then the best thing to do is a lot of these quality initiatives is you follow the data. So you look at what you were doing before, what proportion of patients were hypertensive, what time they were going home, what antihypertensives they were given, what was the readmission rate, what was the morbidity, and then you put a program in place and you said, this is how we're going to manage hypertension in our hospital. We're going to treat severe hypertension within 1 hour. We're going to give them IV antihypertensives. Every severe preeclamptic is going to get magnesium. This is how you're going to manage, their creatinine. This is how we're going to manage their IV fluids. And then you put all that things in place, educate every person. Dr. Mehra, you were saying, like literally a janitor in my hospital knows about preeclampsia, because I have created programs that every person who is in provider of OB provider should know. The midwives, the residents, the fellows, the doctors, everybody should know about the disease because it's a very bad disease. And then you put a program in place, and then it takes time. Sometimes in this postpartum hypertension program I put in place, literally took me a whole year. It takes time because you have to educate everybody, you have to develop the materials, you have to pass it on. Then you have to do some annual competency training for all the people. And then you follow your patients along. Then you create a data form and you say, I'm not going to collect the data, and see if you actually made a change, right? And if you didn't, you can go back and say, what was I expecting and why didn't it happen? So like doing some gap analysis early on and saying, how am I managing my blood pressures? I mean, you'll be surprised. I was surprised when I went to how bad my patients were managed in the emergency department, or it was amazing to me that patients, like people, except for like, they didn't know how much mag to give in a neuro ICU. My patient is seizing. You'll be surprised what's going on with your patients unless you're like physically doing it yourself. So doing some sort of in your system gap analysis to figure out and then work on one part of it or two parts of it, and then follow along 6 months later and say, did I make a change? And sure, you can publish it, but you can also internally publish it and, you know, go talk to your seniors and say, or go back to the people who are helping you with management and say, look, we actually made a difference, right? The other thing I would just add one more thing is one of the things I do in terms of education, I do things like lunch and learn. So I actually bring, and I have a slide about, like, I literally sit with a desk in a hallway in my hospital, and I say, anybody has any question about preeclampsia, come and talk to me. So any nurse can come and talk to me. I literally sit there. The World Preeclampsia Day is coming up, you know, May is World Preeclampsia Month. So you can organize those things. You can galvanize people around it. You can, you know, put posters in your labor and delivery about it, that what are the different programs that you're running in your hospital for management of hypertension. So there are lots of, and that paper that I sent, the Green Journal, it's got lots of stuff. It's all available to everyone. So I would highly recommend doing these quality initiatives. You're trying to, you know, first find the gap, then put something in place and follow and see if that made a difference.
True, madam. So analytically, we'll be improving a lot. Thank you.
I think
Thank you,
PENAI is also one of the quality initiatives, I feel, Dr. Sarosh, because we realized that we probably needed education for empowerment. And so we have to really go after, you know, the pilot and see what we've actually done to these participants with, you know,
through surveys. Yes, we can do that through surveys and see what was their knowledge before the course, and then they took the course, and then you can send them the same survey after the course. And see, I actually have a survey that I give to all my providers, and I actually have a similar to, not as extensive as PENAI, but you can develop small educational courses. But yeah, PENAI course would be a perfect example of saying, did it actually improve knowledge? I mean, obviously it's hard to figure out if that knowledge translated into better clinical care. I mein, that's the ideal thing that we are shooting for, but that makes common sense. If you are more knowledgeable, I'm assuming you're going to provide better care. So in the beginning, we can just say, did the course itself improve knowledge of people about the common topics like Dr. Mehra has about diagnosis of preeclampsia, about risk stratification, about management of patients. So yeah, I think doing a survey on the people who are taking the course will be a great start to see if the course is actually making a difference in educational, you know, kind of status of people.
We request all the delegates to probably fill the feedback forms that we've provided over email and send it to us within 1 hour of completion of this session, so that we can process your certificates. And that is very, very important to us. And I think I would not say we're coming to the end of the session. It's going to be beginning of another new session very soon. But I would definitely want to thank each and every faculty, which include the speakers, the concept builders, and of course our mentors, Dr. Prakash Mehta, Dr. Sarosh Rana, who really, you know, mentored us to this level that we could have got this first live session going, and we have the momentum to run several such, you know, courses. And we thank all the delegates because they've been very interactive. They've been asking us so many questions. We've had delegates from the north, south, east, west, which is very, very satisfying. The office members, I would want to take their names. We have Dr. Meghana, we have Mr. Shrikant, as well as Mr. Rajgopal, who also contributed a lot, talking to each and every delegate and tying up all the loose ends, sending all the emails. We thank Rosh for being our support, for helping us launch this course and taking it forward. And of course, Manasa and her entire team from Medinet for giving us this wonderful platform and taking it across to all our delegates so smoothly. So it's definitely a dream come true for all of us, and hoping we will meet very soon with another set of graduated and certified clinicians for preeclampsia education. Thank you so much.